Hello everyone and welcome back to our channel. When a well-known public figure dies suddenly, it often raises questions that extend far beyond a single individual. Recently, preliminary findings from the District of Columbia Medical Examiner's Office reported that 71-year-old South Carolina Senator Lindsey Graham passed away unexpectedly on July 11, 2026, from an aortic dissection. According to the report, the condition was linked to long-standing atherosclerosis, a disease that gradually hardens and weakens the arteries. His office had initially described his death as the result of a brief and sudden illness after emergency responders were called for severe chest pain shortly after he returned to Washington, D.C., from an international trip to Kyiv, Ukraine. Although speculation quickly spread online because of the sudden nature of his death and his high-profile political role, both law enforcement officials and the medical examiner found no evidence of foul play. Instead, the tragedy has drawn renewed attention to one important question: who should be screened for aortic dissection before it becomes a medical emergency? To answer that question, we first need to understand what an aortic dissection actually is. In an aortic dissection, a tear develops in the innermost layer of the aortic wall. Because blood is pumped through the aorta under very high pressure, it rushes through the tear and forces apart the inner and middle layers of the vessel. This creates what doctors call a false lumen, or a second channel where blood should never flow. As this false channel expands, it can reduce blood supply to vital organs such as the brain, kidneys, or intestines. Even more dangerously, the weakened aorta can rupture completely, causing massive internal bleeding that is often fatal within minutes, if not treated immediately. The frightening reality is that an aortic dissection usually does not happen without warning inside the artery. Instead, it is often the final result of years of silent damage. One of the greatest challenges is that many people feel perfectly healthy until the moment a life-threatening emergency occurs. Because of this, major medical organizations have developed clear recommendations identifying who should receive screening and which tests should be performed. High blood pressure remains the single most important and most modifiable risk factor because it places constant mechanical stress on the aortic wall. People who already have an aortic aneurysm, which is an abnormal bulging or enlargement of the aorta, are also at much higher risk because the wall has already lost much of its normal strength. Other factors further increase the likelihood of structural damage, including tobacco smoking, obesity reflected by a high body mass index, and the use of stimulant drugs such as cocaine, which can produce sudden and dramatic spikes in blood pressure. Several medical conditions also make patients especially vulnerable to progressive weakening of the aortic wall and therefore deserve careful monitoring over time. Certain congenital heart defects, particularly a bicuspid aortic valve or coarctation of the aorta, are also strongly associated with aortic disease. Inflammatory disorders that attack blood vessels, such as giant cell arteritis and Takayasu arteritis, can weaken the aortic wall as well. Meanwhile, stimulant drugs including cocaine and amphetamines may trigger sudden, dangerous increases in blood pressure capable of causing an acute dissection. Genetics also play a major role. Approximately 1 in 5 cases of thoracic aortic disease occurs within families. According to guidelines from the American College of Cardiology and the American Heart Association, anyone with a parent, sibling, or child who has experienced an aortic dissection, thoracic aortic aneurysm, or unexplained sudden cardiac death should undergo appropriate screening evaluation, typically combines specialized aorta imaging with indicated genetic testing. Screening is also recommended for people with inherited connective tissue disorders that naturally weaken blood vessels. These include Marfan syndrome, which is characterized by tall stature, long limbs, and displacement of the eye lens; Loeys-Dietz syndrome, which often presents with twisted arteries, widely spaced eyes, and a split uvula; and vascular Ehlers-Danlos syndrome, which causes extremely fragile blood vessels and delicate translucent skin. So how is screening actually performed? The primary goal is to monitor the size of the aorta over time and detect dangerous enlargement before a tear develops. Most evaluations begin with an echocardiogram, an ultrasound examination of the heart that also measures the aortic root. If physicians need a more complete three-dimensional view of the chest and the entire aorta, they may order either a CT angiogram, known as CTA, or a magnetic resonance angiogram, called MRA. When an aneurysm is discovered, patients are usually followed every 6 to 12 months to monitor its growth. Blood pressure is carefully controlled with specialized medications that reduce stress on the aortic wall, helping delay progression until preventive surgery becomes necessary. The overall strategy is simple: identify dangerous enlargement before catastrophe occurs. It is equally important to understand that screening and emergency diagnosis are not the same thing. Routine screening is designed for people who are at increased risk but have no symptoms. However, if someone suddenly develops warning signs suggestive of an aortic dissection, doctors do not schedule routine screening. They immediately perform emergency diagnostic imaging. CT angiography remains the primary imaging test because it can quickly visualize the entire aorta and accurately identify the location and extent of the tear. Transesophageal echocardiography, or TE, is another highly accurate technique, particularly in unstable patients, while MRI also provides excellent diagnostic accuracy when time permits. All three imaging methods demonstrate extremely high sensitivity and specificity, generally between 98 and 100% sensitivity and 95 to 98% specificity. Although chest X-rays are commonly obtained in emergency departments, they are neither sensitive nor specific for diagnosing aortic dissection. At most, they may reveal indirect signs such as widening of the mediastinum or the classic calcium sign. Physicians may also use the Aortic Dissection Detection Risk Score, or ADDRS, to estimate a patient's likelihood of having the condition based on risk factors, pain characteristics, and examination findings. In patients with a low ADDRS, a D-dimer level below 500 nanograms per milliliter may help rule out the diagnosis. Once the diagnosis is confirmed, treatment must begin immediately. The first priority is to reduce both heart rate and blood pressure, usually with intravenous beta blockers, to minimize the force placed on the damaged aorta and prevent the tear from extending further. From there, treatment depends on which part of the aorta is involved. Type A dissections, which involve the ascending aorta closest to the heart, almost always require emergency surgery to replace the damaged section with a synthetic graft. Type B dissections, which do not involve the ascending aorta, are often managed initially with aggressive medical therapy and close monitoring, although some patients may require endovascular stent repair depending on the severity of the disease and the development of complications. At the same time, managing blood pressure, avoiding tobacco and stimulant drugs, and following recommended imaging schedules for high-risk individuals remains some of the most effective ways to prevent this devastating condition. That's all for today. If you found this video helpful and informative, please give it a thumbs up, subscribe to the channel, and turn on notifications. Thank you for watching, and we'll see you in the next video.